It's an enormous pleasure to welcome you today to the last session of the summer school. We're very happy we made it up to here with no major technical incidents and having many of you joining many of the sessions. So thank you very much for your loyalty, for following us, and for being here today. We believe we can provide today a very exciting session. My name is Josep Figueras. I'm the director of the European Observatory. And the objectives of today's session, as you saw in the title, are to give you a policymaker's perspective. So we'll have the vision, the perspective of Finland at a very high level, the perspective of the Veneto region, both cases with those senior policymakers that were at the cutting edge of making the decisions. We want to hear how they dealt in particular with the area of hospitals. And then we'll have the two multilateral agencies. We have the WHO, Regional Office for Europe, the very high level as well, and the European Commission, and see how they have worked with the member states, how they have been supporting their member states, and what are their priorities now in the next stages of this pandemic. And at the end, we'll have our two friends and colleagues, director and co-director of the summer school, that will be somehow concluding, giving some lessons. But today is very important more than ever. I'll be very grateful for wherever it's worth me being grateful. If you could participate a lot. One, questions, because I'll be I'll be asking questions to our panelists, but Suzy Lesov, my deputy, whom I'm introducing now as well, the co-chair today, she'll be participating with your questions to our panelists. So you will be part of that interview as well, of that debate, number one. And then I like very much if you could, in the chat box, give us lessons and conclusions, taking home messages. As I said, Reinhard and Martin today will be giving us their own conclusions, what they learned, what they think they wanted you to learn and take home. But we'd like to hear what you learn. And if you haven't learned, we have to hear that as well. So what kinds of messages you are taking home from these 2 weeks of the summer school? So let me now, therefore, have all my colleagues on board and introduce them, the panelists today. First of all, I like to have Lisa Maria Voipio-Pulki. She is, well, Suzy Lesov first, which I already have introduced. Lisa Maria Voipio-Pulki, who is the Chief Medical Officer and Director General in Finland, as well as Chair of the European Observatory. As well as Lisa Maria, you have an enormous experience as a doctor, intensive care in hospitals. So it's a real privilege to have you wearing all these hats together today, from the high responsibility to working with the Prime Minister and the Minister on a daily basis of managing the pandemic, as well as your vision, your views, your expertise in having managed hospitals and intensive care units. We have as well Domenico Mantoan, which is the Director General of the Veneto region. So he's the next in charge after the minister, who's really the top civil servant managing the health system. I think he's been delayed a tiny bit precisely with an issue of the COVID, but will be joining us in a little bit. Then we have Natasha Azopardi Muscat. She is the Director of the Health Services and Public Health Department at the WHO Regional Office for Europe. Natasha is part of the new directors, the new team of the new regional director, Hans Kluge. Natasha has a long and prestigious career in the field of public health as former president of UFA and many others. Natasha, thank you very much for being here as well. Then I'd like to introduce Isabel de la Mata. Isabel de la Mata is principal advisor to DG Santé. She is the person, the public health specialist, working with the Director General and the Deputy Director General. Like Natasha, Isabel has been in academia as well, has been in the Ministry of Health, has been attaché. So she's been at all levels of technical advice and policy making. Director General, as I said, in Spain a number of years ago. So she knows very well the policy, the politics, and the technical advice are more than ever. So Natasha and Isabel will enlighten us as to some of the challenges that these two organizations have faced, and they know I'm going to ask them some difficult questions as well that you have in your mind as well. And then, of course, I don't need to introduce, but I still will bring them on camera, Martin McKee and Reinhard Busse, our directors of the school and co-directors of the observatory as well. In fact, if you want to complain, this is the people who should be complaining, the directors of summer school and the organizations, WHO, the commission, and the chair of the observatory and Susie Lesov there that have been organizing the summer school, and Annalisa, who's not there. So you know who to complain as well. So thank you again. Lisa Maria, you've been very kind to provide us a recording, a presentation, a short presentation in response to some of the questions we're talking about. I was asking you in particular, in the debate we had the other day, I was asking you, how do you manage the crisis in Finland? How did you make some of the priorities? In particular, what are the lessons and how the COVID has affected not only the hospital services for COVID, but for non-COVID patients? And what I like very much is you have, and you put that in your presentation, your personal views as well as your formal views. And coming from you, this is extremely valuable. So Lisa Maria, I believe it will be through video if you want to add anything now, or rather perhaps as soon as we see your video, then I'll put you on a screen and we'll discuss. So Annalisa, if you want to put the video of Lisa Maria first, and then we'll open the debate. Thank you.
Good afternoon from Finland, which is a small Nordic country with a total population of about 5.5 million people. Our hospitals are in the hands of the municipalities, who also take care of public health and all primary health and social care in the country. We had a hospital reform about 2 to 3 years ago, when all the acute care was centralized in roughly 20 central hospitals, catering for their own population basis. There are 5 university hospitals, and the biggest one is the Helsinki University Hospital, which has a population basis of about 1.5 million. The distances between the hospitals can be hundreds of kilometers, and that's why we have a fairly extensive out-of-hospital. The COVID-19 epidemic hit Finland a couple of weeks later than the neighboring countries. So the government had good information about what to be afraid of when the state of emergency was declared in mid-March. The lockdowns and other restrictions were installed before the first COVID-19 associated death occurred in Finland, and maybe that's one of the reasons why the epidemic never really became that bad, as was feared in the beginning. After the Emergency Powers Act was repealed, the government and the ministry has no direct powers on the operations of the municipality-owned and managed hospitals. And there is strong reliance on individual responsibility in fighting against the second wave of COVID-19. Currently, there is practically no need for hospital care for COVID-19 patients. And despite this so-called success, government has been criticized of being too slow to react in February and in March, when the information of the pandemic reached the country. Based on the Finnish constitution and the fundamental rights of the citizens, a political decision was made very early to prioritize life-saving ICU care also for the COVID-19 patients in all Finnish acute hospitals. So based on the Special Powers Act, the ICU capacity was more than doubled in 2 to 3 weeks. And of course, separate COVID-19 patient pathways had already been created weeks before that. When the need turned out to be much less than predicted, there was of course some temporary frustration among the professionals, but probably, and they also admit that, we are now much better prepared to take care of both COVID and non-COVID patients in a balanced way should the second wave really hit the country. Because the government and the ministry has no direct operational power over the hospitals under usual circumstances. I have to admit and give credit to the pre-existing voluntary ICU network and quality registry, which has been there on the national basis already for 20 years. This network was the key to rapid action and seamless communication between the hospitals and the government, including me myself. And I think that it's one of the key observations that COVID-19 patients should be and were hospitalized using similar criteria than any other patients. So the ICU admission criteria, patient profiles and outcomes were openly discussed, peer-reviewed and communicated to politicians and to the public. The space for COVID-19 patients in ICU units was of course built by cancelling non-urgent surgery, shown here by the blue line. I apologize for some of the Finnish in the graphs. And some of the operations were postponed to levels that we usually only see during the summer holiday weeks. Honestly, in some hospital districts it will take more than a year to catch up, which of course has created criticism because the ICU units were never really filled by COVID-19 patients. A little bit surprisingly, also emergency surgery, shown here by the yellow line, was reduced, mainly due to fewer trauma cases during the lockdowns. Of course, the long-term well-being effects of the epidemic should and will be followed, particularly because we saw, somewhat surprisingly, also a dramatic reduction in the primary care visits, most remarkably in oral health and school clinics, which were of course closed for roughly 3 weeks when the schools were closed in March and April. Digital services were increased both in hospitals and in primary care facilities, but not sufficiently to close the gap, according to preliminary analysis. It helped to create separate facilities for suspected COVID-19 patients, also in primary care, and now it seems that this phenomenon is largely over. We also had local and national media campaigns to encourage NCD patients to attend their regular visits and acutely ill patients to call 112. I was chairing a working group, which is still existing, that brings together hospital physicians, managers, epidemiologists, and communication officers. We put together a weekly report on the epidemiological situation and communicate it both to the media and to the government, including the Prime Minister. It is my personal experience that since hospitals are centers of excellence, they also have lots of information about the epidemic, how to treat the patients. They have their national and international networks. But during the crisis, they needed new kinds of epidemiological modelings to plan and adjust their human and material resources adequately. For policymaking, combining national and local modelling and comparing predictions with real-time observations really helped to increase credibility of this exercise in the eyes of the politicians, the media and the public. This is particularly true because conflicting expert opinions are difficult in acute crisis and they consume a lot of energy. So we tried to identify uncertainties together, and I hope that we also learn to communicate them openly. Finally, in the eyes of the politicians and the public, staff and patient safety are essential. So despite the so-called success of taking care of the epidemic, and particularly the hospital and ICU care part of it, failure to prevent some case clusters in primary care wards and long-term care facilities were politically the most difficult issues and will probably be also so in the future. Thank you.
Thank you. Thank you very much, Lisa Maria. That was short, short, sharp, and clear, and it's exactly the kinds of lessons we wanted to hear. Can I ask you, please, participants, to go into the Q&A and include some questions to Lisa Maria that we bring on this debate, so you are also part of this debate, because at the moment I see the Q&A totally empty, and Susie is looking for questions from you. Lisa Maria, there's many points you raised which I found really, really useful. One that you made in other occasions as well is the existence of these pre-existing structures. The fact is these ICU networks work very well already in advance, and they were able to be put in place. You were not a firm believer of putting in place these things all at once and quickly. Another one that I'd like to ask you a little bit more, because there's been a lot of debate, is this idea of centralized, decentralized. So one of the questions we have in our COVID monitor more often is how centralized systems done better or worse than decentralized systems. And you seem to say at the beginning, well, they were quite decentralized. What is your opinion on that? I mean, the fact that they were decentralized, did that mean that they were more effective dealing with the crisis? Are you missing perhaps more coordination? What are the lessons that one can draw? Very context specific, but still, what kind of the lessons that one can draw from Finland, Lisa Maria?
Thank you, Joseph. That's a very good question. Of course, my presentation only was on the hospital side of the COVID-19 response. So most of the testing and the isolation and tracking, tracing, and also care of the patients actually did take place locally in the primary health care and at home. For the hospital system, so we had this debate about centralization or decentralization 5 years ago when we started to plan for the hospital reform. But particularly the care that I'm here talking about, which is really hospital care, and with ICU, I mean real ICU where you need all the facilities for organ support. I think that the centralization in a country like Finland, where we have, actually it's the staff, it's the skillful staff in the hospitals, intensive care units, that's the rate limiting factor. And so I think that the only way to survive with good quality care in a country like Finland is to centralize. The problem is that the population basis of the central hospitals is vastly different. And so some of the ICU units and the central hospitals to begin with are fairly small compared with, for example, the Helsinki University Hospital, which is one of the biggest in Europe. So, of course, there is also differences in the amount of expertise that these central hospitals can provide to their populations. And that's why I think that it's extremely important that they work together, they talk to each other, they inform us, and actually having weekly meetings was not enough. We had daily meetings when the crisis was really on. So we sort of substituted with these meetings, and of course with the special powers, which were not all needed, but were there just in case that we would have needed them. They substituted for the decentralization. Over.
Excellent, thank you. Could you put all participants, panelists on the screen, please, because I like to involve some of the others. Lisa Maria, another area that I find fascinating, and for us in the observatory, and for you being the chair of the observatory as well, is this idea of science to practice, science to knowledge, to practice, to policy. We've been saying for some time that in the case of COVID, science, policy, and politics have become all one. And you personally, and Finland as a country, always been paying lots of attention to that connection. However, you also shared a bit of frustration. You hinted to it in one of your bullet points about the complexities when science is not very certain, and science wasn't very certain at the beginning. In a minute, I will involve Martin on that debate. We had another webinar today talking about that. Lisa Maria, can you elaborate a little bit more about many of the people here and listening to us are working with policymakers like you, providing you evidence support. How did you live that, and any lessons to take that forward?
I have a very simple answer to that question. I have great trust in the top clinicians in our university hospitals, and sometimes even in smaller hospitals. And in a situation where there's no clear evidence, no randomized controlled trials available, you have to trust the old-fashioned clinical judgment. And of course, we know how to provide basic intensive care. Very quickly, they learned that this respiratory failure is not like any other respiratory failure. And rumors go around. They call their colleagues in other hospitals in Europe, sometimes using the reference networks, sometimes using just their personal connections. And I heard from them what will work and what will not work based on that first-hand experience. This is the way it goes. It's not that uncommon for critical illness because there is not that much old-fashioned randomized controlled trials in critical care. So these people were not bothered by that. They were eager to learn if somebody has some evidence, but they could also live and practice medicine without. Over.
Thank you. In fact, Martin, this is something we're discussing in your session, and we discussed also yesterday with colleagues of the European Commission, the rapid putting in place in some countries like the UK of these networks of clinicians sharing. But Martin, I'd like you to go a bit further on that and reflect a bit about the precautionary principle of science and about the populism. If you could tackle these two areas, please.
Well, start with the precautionary principle. I think now, I mean, it is clear. Let's just start off with something that is fundamentally obvious now. We've just had new Office of National Statistics data from the UK published this morning. The UK has done worst in Europe in terms of outcomes from COVID, with the highest level of all-cause excess mortality. So the question is why? Why has this country, with all of its talent and all of its ability, done so badly? And I think one of the concerns we have is that maybe we didn't quite get the science right. And by that, I mean, we've been teaching evidence-based medicine for a very long time. And we're all aware of how to critique a paper and the limitations of research and so on. But sometimes maybe we take it a little bit too far and we say, well, you know, the absence of absolutely clear evidence with a meta-analysis and replicating trials and all the rest of it means we can't actually do anything, or we delay. And I think that some countries that had less scientific capacity recognized that and actually acted in advance. So I think that's been a particular concern. Now we need to look at this in more detail. The populism I'll just mention very briefly. We've recently published a paper about populist leaders. Now the rankings of countries have changed a bit, but at the end of June, it was clear that the 5 top countries in the world in terms of cases were the United States, Russia, Brazil, the United Kingdom and India, all of whom have leaders who have in various ways rejected science, appealed to populism and so on. And we tease out in that paper why that was the case. Now, they're big countries, of course, but even so, we can identify a whole series of failures of leadership by populists. Now, there were other populists who actually did quite well for different reasons. So we need to recognize that too. But it is quite clear that if you reject the concepts of science and the Enlightenment and evidence completely, you're going to have problems. Similarly, if you're too fixated on getting everything clear about the evidence and you're waiting for that meta-analysis which establishes beyond all doubt, you have problems. And the answer is that you need to work somewhere in the gray area. Going back to what Lisa Marie was saying, I think that one of the things we have learned is, in the session that one of the sessions that I ran, we had clinicians from England who were talking about the work that had been done in terms of understanding the very complex multi-system nature, and it's stuff that I've written on with clinical colleagues, looking at the way this virus attacks a whole range of tissues within the body, which have got ACE2 receptors on them, which is almost everything, in fact. But in that process, it was possible to get networks working within the country, but our attempts to reach out and engage with clinical bodies, professional bodies in the rest of Europe was very, very difficult. And what was clear that in a number of other countries, you didn't have those structures in place of clinicians who would work together, and particularly across specialties, to get respiratory physicians talking to immunologists, talking to cardiologists, talking to neurologists. That generally was not happening elsewhere. And we had a real struggle. And then finally, again, and as people who know me will know, I rarely say many good things about the United Kingdom, even though I live here. But one of the things that we did very well was that a very high proportion of patients admitted were put into clinical trials. And they were put into a structured system of clinical trials, not a little trial in one hospital and another one elsewhere, all duplicating activity. That is something that we failed abysmally at a European level. You know, that should have been done at a European level so that every patient admitted to hospital or treated, but particularly admitted to hospital across Europe, should have been entered into multi-center trials. And I think when all of this is over, we really need to look at our structures of engagement with the clinical professions and engagement of the research bodies and engagement with the European bodies. Find out how we do not make the same mistakes again, because that has been a horrendous wasted opportunity.
In a minute, I'll go to Natasha and Isabel. Isabel, your colleagues yesterday, they were talking about these clinical networks they set up based on ERN. So let's park that there, because I want to say a little bit more about that. But Susie, seeing that you're anxious and seeing the number of questions, could give us a sense what our colleagues asking, and how can we direct some of these questions to Lisa Maria and some of the others? What's the mood out there?
It's funny, a lot of the questions are grouping around second wave and also about epidemic control. So not directly looking at steps, as Martin was talking about, in terms of how the hospital is managing, but going back to the presentation of Lisa Maria about how there were meetings and connections and the monitoring and things. But there is a specific question about whether fever hospitals might have a role during a pandemic, and isolation of subjects, and whether it interfaces, of course, then with all sorts of wider measures about emergency lockdown and what kind of policy responses in terms of controlling epidemics. There are questions I think we'll come back to later about what are the things that hospitals have learned for the long term, and what are the policy and being agile in terms of policy-led lessons for the longer term. And I guess you'll want to come back to all of that. And also a couple of things on the chat, some concerns about the role of professionals and their adaptability, also about the complexity of getting remuneration systems and other factors outside of the hospital right, and the links with the local community. That's a lot, so I'll stop. Sorry, Giuseppe.
I like colleagues in the panel to take some of those. I wrote some of those down, but clearly there is an interest about the second wave to talk about. I'll bring you back, Martin, Reinhard, and all of you in the second wave later on, looking towards the future. But perhaps going back to Finland now, Lisa Maria, you have very clear lessons. How are you preparing now for your next wave in Finland? Are you strengthening your coordination mechanisms, the clinical networks that exist at the moment, your surveillance systems? How are you preparing now for this likely next wave, although the numbers seem to be still okay in Finland? You are muted.
Okay, unmuted, I hope.
Yeah.
Good. Yeah, since we didn't have that many cases, so the population is quite vulnerable. We managed to protect the vulnerable groups fairly well, maybe even too well, by isolating people over 70 years of age to their homes, which has been heavily criticized afterwards. We don't have practically no masks being used in the country. That's an issue of debate. But above all, the pressure is on the primary level. The municipalities who are responsible for organizing testing, tracing, isolation, and care of the patients. So the second wave is a real threat. I don't think we have a problem with the university hospitals or even the central hospitals, because now we had this major exercise and we know how to build the capacity back again, should the need come. But I don't think that much of real clinical cases will be politically tolerated anymore. So I think that now that we weekly publish, latest just a couple of hours ago, an analysis of the epidemiological situation in the country, should we have the first hints of the second wave, be that local surges or a national phenomenon, there would be very rapid political response. There is debate every day in the media about what kind of restrictions we would then come back. On the other side is the impact on the economy, on the impact of the population's well-being in general. And honestly, I do believe that we try to manage without the Special Powers Act. The threshold is really, really high because that violates people's fundamental rights. So we try to keep the fire low and keep our fingers crossed. Nobody knows what will happen.
Well, WHO knows, right, Natasha? WHO knows what's going to happen. That's why we trust you so much. Seriously now, both WHO and the Commission have done a great job, even sometimes being criticized for not being fast enough. But let me link that to both of you. First, Natasha, how are you preparing? What are your priorities? Let's not look far backwards, but forward. How are we preparing? What are your priorities to move forward? And how are we going to support our member states, your member states, our member states for these next challenges that Lisa Maria was so nicely outlining? Over to you, Natasha. Unmute.
Thank you, Josep, and thank you to Lisa Maria Martin for having already put some really important pointers forward. Of course, we don't have a crystal ball, Josep, but we do have an increasing amount of science as well as policy experience that should help us to prepare better for what is coming. I think people are talking about a second wave. We don't really know what this wave will look like. What I can say is that within the European region, there are a number of countries, particularly in the eastern part of the region, that are still battling a very high number of cases on a daily basis. Furthermore, we see a number of countries that are already seeing pockets of resurgence. Whether these pockets of resurgence are going to be controlled well because of the experiences that we have, the swabbing centers that are in place and everything else, so as to prevent them from becoming a larger wave or not, is still something that we can't say. We don't know. What is becoming increasingly clear also is that sometimes it's somewhat artificial to speak about countries, and it's better to speak about areas. Because within some larger countries, you find that it is only a region that is affected. And then in some areas, you see that there is actually a cross-border epidemiological situation across countries. What are we doing as the regional office for Europe? We are trying to respond to some of the very difficult questions that countries are putting forward to us. And of course, it is to be expected that when some of the countries that have top-notch experts and clinical expertise come to WHO, I mean, here we are talking about some of the countries with the most advanced health systems, best universities in Europe, come to WHO asking, for example, how are we going to prepare for the fall when we are going to have possibly, besides the normal influenza, RSV, ILI, which is a number of people in Lisa Maria's position, as I have been before, know that there are a number of weeks in the year because of Europe's demographic situation when our health system is under duress and under stress. This year we are going to have a new intruder, COVID, on the block. What is going to happen? How should we react? Well, in truth, there are various possibilities. And I think the most important message is that we should not be passive spectators awaiting the onslaught, because there are actions that we can take. And these are some of the policy considerations that we are preparing at the moment based around the principle of prevention, because the measures that we will take to prevent COVID will work also for influenza, ILI, etc., or conversely. And we have learned a lot about what can be done to actually keep the rates of infection down. And in fact, what we are seeing is that in some countries in the Southern Hemisphere, where they have COVID well under control, they have also witnessed low levels of influenza. Whether this is something to do with external factors or whether it is a result directly of the fact that maybe there hasn't been so much travel, so there hasn't been so much mixing of the population. But definitely, I think the key message is that we want countries to realize that there are steps that can be taken, that we can't be complacent. We need to continue to ensure that our capacity continues to be strengthened. And I think since the session is around hospitals, one of the key lessons that we have learned from this spring is that we need to protect our hospitals also. We need to protect our hospitals by ensuring that we have mechanisms to work at the domiciliary level, at the primary care level. I think this is going to be essential for the winter. Somebody mentioned fever hospitals. I would go one step further and say already in the community, at the level of primary care, how do we distinguish and create the appropriate firewalls between the pathways of patients exhibiting the non-distinguishable symptoms of COVID, influenza, RSV, etc., as opposed to patients who are not presenting with these symptoms, but who we need to continue to care for because essential health services have been adversely impacted. And the more we can strengthen out there, the better we support our hospitals. And the hospitals, we are not talking about the walls and the infrastructure. We are talking about our staff, the clinicians, the frontliners. It's those people who we need to protect and support. Of course, the other very big issue is population engagement and behavior. And on this, WHO, for example, at the moment is working also with ECDC, with headquarters and a number of other agencies to try to understand how we can best support member states who are struggling with how to safely reopen schools, which is so critical for the economy. And if you will just allow me, Josep, to reiterate the three key messages that our regional director, Hans Klug, is putting forward in terms of what have we learned from this COVID pandemic. The first lesson is that even the best health systems were not prepared enough. That is what he says. I like to add, but now we can be better prepared because we have learned important lessons. The second one is the principle of solidarity. Solidarity within countries, between regions. We have seen in countries that have organized themselves well, that as the virus tracks through the country, they have organized even the hospital networks in such a way that when they are reaching a certain capacity, they transfer patients. That is one level of solidarity. Another level of solidarity is cross-border solidarity between countries. And the third one, I think this is really critical going forward, that this is not some competition between lives and livelihoods. And it's so naive to think that we should let down our guard from all the preparedness and response and mitigation measures to open up the economy, because in fact it is by bringing the situation under control that we are able to safely open up the economy. Thank you.
Perfect, perfect. I think these are three messages to take home that are very, very helpful. Susie, is there any questions there you want to bring on board at the moment? With regard to what Natasha was saying?
They're questions from before, but they relate, which is a little bit around the nature of networks and around public engagement. On the public engagement, there's quite a bit of sense that, you know, there is a gap between what the public health community and politicians are doing and the public, and how to unite those. So there's issues about how you bring politicians and the population onto the same page, how you try and get maybe politicians to listen more to public health professionals, questions that like that, and also some questions about, you know, whether there's been enough scrutiny of the evidence and stuff, which I think kind of tangentially relate. Over.
Well, maybe Natasha, you could reflect on that, and maybe if Martin, Reinhard, or any of you wants to add, Isabel, Lisa Maria, on there seems to be a lot of interest about this linkage between the politicians, the evidence, the managers and the public. Can I have some more reflections on that? You want to start, Natasha, on that? and
Sure,
how
I
from
think
WHO you can help with that, and certainly from the Commission as well, being perhaps to highlight, Natasha, from WHO, there's been this conference in headquarters called Infodemics that Tedros, the Director General, has been pushing very much. Could be one of the issues, one of the areas actually can support not the fake news, but fighting against the fake news. Go ahead.
I think, Joseph, that this is really one of the critical challenges for us as WHO, as a mirror of our countries. And in the European program of work, which has two overarching objectives, the second objective is how can we support our health authorities, our health services managers, and in a situation where increasingly leadership is being challenged, the leadership of health authorities is being challenged, on the one hand by the public, by a discerning public, on the other hand by this whole overwhelming amount of misinformation and disinformation, which is sometimes also linked to some of the political statements or misstatements that may be being made. And this is also very challenging for our public health leaders who have found themselves very much in the eye of the storm, I like to say, having to navigate, on the one hand, the uncertainty of the science. And I mean, science is always about challenging the known paradigm with the emerging evidence. I think what we are seeing now is that whilst in our grandparents' lifetime, it used to take perhaps 10 to 15 years to arrive at a point where you amass enough knowledge to overturn what you knew previously. In the lifetime of the 6 months of pandemic, the speed of generation of knowledge and evidence has changed, the pace has changed. So people start necessarily getting confused and they say, but how come you were telling us 3 months ago that there wasn't enough evidence to support the use of face masks, and now 3 months later you are telling us that there could be enough evidence to support the use of face masks? And I think we need to be far more nuanced, careful, but also almost assertive in the way in which we communicate, to make it clear that with a certain amount of humility too, that what we are sharing is the best knowledge that we have at a point in time. And it does not mean that in 2-3 weeks' time, when more knowledge emerges, that we will not be changing the picture. I think this is really the key to it.
This has been one of our main lessons looking at resilience. Sorry. Go on.
No, it's just that the changing message sometimes then leaves a wedge for populism, for orchestrated disinformation to take up the space. And there is clearly a science to this that we need to capture better.
Yeah, sharing uncertainty has developed trust, has developed compliance, and we haven't done that very well. Lisa Maria, you wanted to comment to this?
Okay, yes, thank you. Very good points. Just very briefly, I've been attending the government sessions on a regular basis during the first wave, because they invited health authorities from the ministry, public health authorities from the DHL to give reports to the cabinet on a regular basis. So during the first wave, we put health first. But now that we are facing a lengthy time when we don't know what's going to happen to the epidemic and the pandemic. So it's the role of the politicians and the ministers to find the right balance between economics, social consequences of isolating the vulnerable groups, or even have lockdowns. It's their role. And I personally have good experiences of the ability to do that. There have been many reports from top scientists in social sciences, economics, and so that they also read in their sessions. And then we discuss and try to find an educated balance between the different views. So I think the key issue is that how far do we prioritize health? How far can we go in prioritizing COVID-19 or other infectious diseases during the next few months. Over.
And that will have to be made very, very transparent. Societal involvement and debate will be very important. Isabel, I'd like now to move to the Commission, who's played a key role on many of these developments. What are the priorities of the Commission at the moment as we go to a second wave? And what are the areas where you have played a role and you believe can play an increased role in supporting our member states for the pandemic?
Thank you, Josep. And the difference from the European Commission is that we have an overall role and overall vision, so not just related to health, but in other areas. And the Commission has been working in all these different areas, for example, from the supporting the research on vaccine diagnostic or testing to the repatriation of EU citizens that were stranded abroad, from providing funding through the coronavirus response initiative to issuing guidelines for the different measures to stop the spread of the virus, from ensuring that the flow of goods and workers was continuous cross-border, to being buying through joint procurement different goods. So it has been trying to be global in all the different areas that have been affected. On the area of public health, the measures that we are taking for the next months, apart from continuing with the joint procurement, so trying to ensure that the member states are prepared, that all the different material is available to the health services, not the hospital, but all the health services, and also working with them in the emergency support instruments. So that means that we are negotiating, as you for sure know, in the vaccines, some of the treatments, trying to accelerate the clinical trials for the vaccines, of course, but also for treatments, new diagnostic methods. We are also doing something that could be interesting, that is related to the session yesterday, that is working with the intensive care medicine professionals to do training for other health professionals that could support, if there is a second wave, could support the intensivists and having extra professionals. We are working with the international organization or NGOs also to increase the testing capacity in the member states. So there is a series of different actions where we are trying to prepare for the potential next wave, also to respond to the outbreaks that are taking place now, but also to prepare for the future. I will not say to avoid that this will happen again, but to be better prepared in the case that there is a new pandemic, or that there is a better cooperation. I mean, we are preparing the new EU for Health program for the next period, 2021-2027. We are discussing if it will be necessary to change the way the ECDC is acting. I mean, to give more powers, more empowerment to the ECDC and also to the European Medicines Agency. So trying to see how we could better collaborate with the member states. We have always been, or we use very often this excuse that there is very few competencies in health in the European Union, but we are trying to work to solve this issue. I mean, to make sure that we are all doing our best and that we are improving the collaboration cross-border, because we have demonstrated that the national measures could be effective, but at the end, what we need, this is a worldwide crisis, and that need to be solved with our worldwide measures. And of course, at the European Union, we are trying to do that. Oh.
For both organizations, Natasha and you, Isabel, one of the things that you all highlighted is the vulnerable population, the equity and access, and certainly the purchasing of the procurement of vaccines, the procurement of treatments, and the access of these treatments across geographical areas having very different levels of income in Europe. And within those countries is going to be an important one. How much more can you do, Isabel, on that area? You were talking about procurement of ventilators, procurement of protection equipment, prevention protection equipment, procurement of vaccines. How much more should you go, can you go in that direction as Europe?
At the European Union, we have been working in the joint procurement. We had legislation, a framework that allowed for us since several years ago, and we have been procured in two different ways. So there are two different mechanisms. One is the rescue mechanism, that is that we directly, the Commission procures through the different mechanisms that especially have been used by DG ECO, so for the intervention force that we have, directly, and we distribute to the countries that request that. And the other one, that is the joint procurement, where we prepare the contracts, and the member state request the different material, the quantities that they need. Until now, we have been procuring personal protective equipment, ventilators, testing and laboratory material, PCR machines, and etc. Well, those and ICU medicines also. And now we are working on the vaccines, but at this moment is under the emergency support instrument. So we are, I mean, there is nothing to procure, not yet, you know. So we are just trying to establish contact with the companies to be able to procure in the moment that there will be something to procure. We have also procured treatments, the remdesivir, and we will be doing something on plasma collection for use as convalescent plasma, but also to produce the immunoglobulins. So this is an area where we have a lot of experience, and we have been trying, but we are not doing alone. This is done, the joint procurement is in collaboration with the member state.
Excellent, thank you. Can I ask you a difficult question to both of you? Let's imagine that you are not on video being broadcasted by YouTube and you're not recorded. Both the organizations, the WHO and the European Commission, have been criticized for being slow. I think there's been lots of fake news about that, by the way, lots of fake news and lots of blaming your organizations, but being slow, not reacting effectively, being too bureaucratic. What would you say to these criticisms that indeed I don't share at all, because I work very closely with both of you and I know that's not the case, but how would you want the public out there, the criticisms are there to see your reality, and what would you want to be able to address this image and make the changes you need? You want to start there, Natasha, and then I'll ask Isabel?
Sure, thank you, Josep. Well, let me just always start by saying that there is certainly always room for improvement, and it would be wrong not to reflect and find ways of doing things better. And I think it is very much with the spirit of a combination of humility and determination that we are entering also this new era in WHO Euro under the leadership of Hans, with a new European program of work. Having said that, I would like to emphasize the number of missions on the ground that have taken place and that are still taking place across the European region, in the Caucasus, in Central Asia, in the Western Balkans. But not only, we have also been very active with Italy and Spain, and are still following up very much over there. And I think this is the work that is what I call the silent but effective work, where you really just send out mission after mission and reach out to people on the ground and visit the hospitals and support, not only by providing technical advice, but also by very much providing the visibility and the moral authority and support, reaching out. And I think that is very strong, but maybe not enough visible. And then there is, of course, a second tier where a lot has been done. Maybe initially it was a bit slow, but then we picked up, and we are still working, because as we know, this is not behind us. And this is in the way the office has almost entirely repurposed to produce the technical guidance. We have worked with you on the platform and monitor, but we've produced a series of technical guidance on primary care, on long-term care, which is again a huge issue which remains unresolved and needs far more attention. Maybe the area where we still can do better is to anticipate and to take up the space even where things seem to be uncertain. And this is where, as WHO, we have a convening role, and we need to recognize better the power of that convening role, where in the absence of strong scientific certainty, the fact that we bring colleagues together at sub-regional level or at regional level, and they can take joint decisions based on consensus, gives in a way an important sense of shelter, of support, of shared response, but also, I think, helps to build confidence and credibility with the population, because one of the hugest sources of mistrust and distrust tends to arise when countries with roughly similar epidemiological profiles are seen to be taking very different decisions, particularly if they are neighboring countries. There is a similar language. They share the same media platforms.
Yeah, good
and
potential there to learn. Yeah,
where we can do better and faster.
So if the WHO didn't exist, we need to create it. And perhaps, Natasha, is all about communication, what the WHO is doing, which I think applies very much to Isabel and the Commission. Isabel, how would you address the fake news about you guys having not been effective enough and so on?
Well, I think that there are two different areas. In one side, it's very easy to predict the past, more difficult to predict the future. In this pandemic, situation has been changing every week and even every day. And we didn't know anything about the virus before. We knew very few. So we have been adapting, and I think that for the normal situation, we have responded too quick. There is a second area that is when we are procuring things, so buying things or doing, we need a minimum of process that can guarantee that things are being done in the right way. For example, usually we have the procedures to approve any new regulation of etc. So the internal process of the Commission that takes 15 working days. Now my record at this moment is 1 hour. In 1 hour we need to approve everything. So that means that you need to carefully check, read, exchange and etc. before to approve something. We have been buying, I don't know, different materials. You have mentioned ventilators and etc. We need to check that those materials are the right one, that complying with all the necessary characteristics and that are not going to do more harm than good. And this takes time, and this sometimes maybe we don't communicate well, that we cannot just go to the shop downstairs and buying something, but that we need to procure many times from abroad, and we need to bring them back, but we need to test and retest and retest, and sometimes we have some difficulties. This information has been one of the main areas where the Commission has been working from the beginning. We have been in contact with the social media. We have had exchanges with them to try that the platforms are promoting the adequate content. We have identified more than 300 disinformative narratives. We have updated in a specific website all that and trying to pass the right information. And we are working on that with all the other partners from WHO to the G7 or the NATO. So I think that we have been working. Maybe we are not communicating well what we are doing. For sure, as Natasha said, that everything can be done in a better way. But I think that the reaction has been quite quick. And as soon as the treatments have been available, we rushed to try to procure some of them. As soon as the vaccines are being developed, we are trying to discuss with the company for that. And we have had continuous discussions with the ministers of health every week until 1 month ago. And so I think that the response has been adequate. Everything can be improved, of course, and we are learning every day, but I think that we are doing our best.
I think that's very, very helpful. I hope colleagues participating today realize the complexities and the checks and balances that you rightly have to go through, and how much flexibility and speed you have managed these days. And certainly with the next wave, you'll be able to prove how many of the vaccines will be there available. Are there any questions? Because actually I want to move go ahead, Susie. Are there any questions related to what's been said?
There are two, which is about this interface, a couple around the interface between this kind of policy and politics interface, coming back to it again. So the things that Isabel has been talking about, but also how you manage to get a long-term talk about health and the economy, the place of that in the future as we go forward, how you try and get the health issues into the wider political debate, and the misuse of COVID by some politicians. And quite separately, just for you to have in the back of your mind, quite a lot of concern about burnout of medical staff, how they can sustain the effort, and of providers in general. So it doesn't fit here, but I wanted you to have it in your head for coming back to at some point. Over.
Something that Natasha was highlighting clearly, and also I know the Commission, they're looking very much at the migration and the problems of staff in our member states, the conditions of work and so on. But let me try something now. I have a voting for you, for all of you, a bit of a surprise, and for all of you out there listening and following us. Can you put the voting question, please? And then participants, panelists, I'll ask you to react first. Perhaps Lisa Maria, if you don't mind, I'll like to go back to you and react first to this voting, this polling that I want to do. Because I'm now moving this session towards the future, basically. I'm looking now towards the future. What have we learned? How we move forward? And so on. And one of the key questions is the one you have on your screen. If you don't see all the answers, please expand your screen, because sometimes, depending how you open it, is only part of it. Not that you have 8 answers in there, 8 options. It says, arguably, the COVID-19 pandemic has accelerated a range of hospital-based innovations. We've been talking about the opportunities, the disruptions that the COVID has caused, and perhaps the opportunity, the silver lining, if you wish, of the COVID-19 in terms of innovations that should result, hopefully, in future efficiency and quality improvements. So I'm going to ask you now to choose 3 out of the 8 options that you agree most with. Please note that you can cheat, but I hope you won't, please, because in fact the system doesn't allow you to click all of them, at which point it's not going to be very helpful. So I'll ask you to go through the pain, as any policymaker should do, to choose only 3 of those. And those you have the opportunity to, you have had the opportunity to look at. It's been part of the summer school. We've been talking about strengthened hospitals and clinical networks, something that we heard yesterday and before yesterday in Martin's session, and yesterday in the European Commission session, and very much a message today from Finland as well. 2, we talked a lot about the increase, very, very fast increase of IT, telemedicine, data sharing, unprecedented. We talked about better teamwork within and across the specialties and across different professionals, something we saw happening very quickly again, as some real innovation thanks to the COVID disruption. Improved models of care and patient pathways, been a lot in the summer school on that. Clinical leadership and innovation, in adopting innovations. Many clinicians have seen themselves taking the leadership and taking the reins and being in the driving seat. And Martin was taking this issue home, as well as Reinhard, about more efficient clinical research. But I have 2 tricky answers there as well, which I'd like you to consider. Number 7 is, well, no, really. None or very few of these innovations that you accept exist will progress, will be sustained after COVID-19, will go backwards. So do I have any cynics, or not cynics, skeptics, sorry, in the audience today? And number 8, the opposite is true. Sorry?
I'm sorry, but there's a problem with the voting system. It will only let people make one choice. Sorry.
Really only one choice. Okay. Annalisa, you know why that's happening, because we discussed that about, I'm not blaming you, of course. Some of the technicians may got that wrong. So you can only choose one of those. Yes, I can see that
Sorry,
as well.
I apologize. Most probably, yes, when we did the test just before, yes, lost. But we can close it and reopen it, if you
Okay,
allow me to do it.
Do that, close it and reopen it, please.
Thank you.
And meanwhile, I like to hear a bit, Martin, you were offering earlier about this next wave. You've been all talking very nicely about how primary care needs to be different, hospitals need to be different, different models, but give us a bit more granularity, please, about how. I mean, Lisa Maria, you must be worrying and facing that now. How do we do that? Do we have dual systems? Do we have hospitals only specialized on, like we have in the Veneto? I know that in Finland is not possible, given the geographical nature of it. How do we catch up, Lisa Maria, in all these cases, all these waiting lists that you have fewer perhaps that countries have many, on other cases we haven't seen? Natasha, you're talking about the storm of the flu and the COVID. How are we going to change those hospitals in the next wave? How are we changing them? Can you give me more granularity? Our participants want to hear that. Who wants to start with that? Martin, you were offering earlier, and then Martin followed by Lisa Maria.
Yeah, well, first of all, I think we should avoid talking about a second wave. You know, a second wave was what we saw in 1918, whenever you had an influenza virus that was changing, which was where transmission was affected by the seasons. That's clearly not the case, because we've got high levels in the southern hemisphere and the northern hemisphere at the same time. And so the Financial Times and others talk about resurgences. Essentially, what we're seeing in many countries is that we never properly got it under control. We didn't do what New Zealand did. And as a result, in a country like the UK or Belgium or a number of other countries, Israel, for example, or Spain, opening up far too early without all of the systems in place for finding, testing, tracing, isolating, and supporting. And I stress those five. It's not just the testing and tracing. It's having a strategy. And relatively few countries have actually had a strategy. They've had bits and pieces. So I think there's a huge issue there. So I think we will need to recognize that we're going to have resurgences, which are going to be different in different places, are going to affect different groups. In some countries, it may be, and is increasingly, we're seeing in a number of countries, young people congregating in hospitality venues, but also migrant workers, low-paid, often undocumented migrants, be they in garment factories in Leicester or meat factories in Gütersloh. And so all of these things are going to happen, but unfortunately, too many governments have failed to put in place the surveillance and control and support systems that they should have done during taking advantage of the opportunity of the lockdown. I think they just sort of put their head in the sand and hope that things would be all right.
Excellent, thank you. But as far as clearly in these resurgences and these outbreaks, these surges, you are mentioning, of course, tracing and testing and tracing and isolating will be very, very important. But for the health services, for the delivery, well, could we go a bit there? Lisa Maria, you raised, or you, Martin, and then Lisa Maria.
Well, I was just going to say, we just need to look at what other countries that had SARS and MERS did. You know, there was a lot of work done in Singapore, for example, making sure that you had two pathways through hospitals and redesigning them. The problem in a number of European countries, like sadly England with the private finance initiative, and Portugal and some other examples, is that once you've built these hospitals, it's almost impossible to change them. So we're stuck with them for 30 years. That's a huge problem. Which was warned about at the time. But that clearly, you know, we need to learn from what Singapore and Korea and other countries have done. It's not difficult.
Flexibility of the structures.
We've been saying it for 30 years, but nobody listens.
Yes, Susie, you seem to want to come on board before I go to Lisa Maria?
Just to encourage some sort of feedback on the issues around workforce and burnout again.
Okay, excellent. Maybe Lisa Maria, you want to add on to that on the reopening of the on this transition, in this duality, and then perhaps I can go to Natasha, on the burnout. Lisa Maria? Yes,
Oh, yes.
Now you are.
Yeah,
unmuted.
thank you. So luckily the lockdown was quite short in Finland. And so most of the hospitals and hospital districts and even primary care centers are able to catch up fairly quickly. The problem is more about the budgets because they are paid by municipalities and the economic situation overall is bad in the country as everywhere. So how do we maintain sufficient budgeting and financing of the health system is one of the major issues for the municipalities right now. Of course, that is a driving force for the reform, which is once again on the table. And the new act is under public consultation right now. So I think that this experience has given even more initiative and incentive to the health and social care reform, because we need even more integration between the social, primary and secondary and tertiary health care. I think that one of the key issues for us is to go back to the basics for infectious diseases control and make sure that there is enough expertise, enough staff for the testing and tracing and isolation and care strategy, which is the cornerstone of the government's present COVID-19 strategy. There is also a mobile tracing app, which needed new legislation. But then there is another thing which is specific, I guess, for Finland, is that we have some new legislation coming, which gives the regular authorities more powers to close schools, institutions, which we already have, but there are certain limitations in the legislation, particularly when it comes to things like restaurants and shops and so on. So that's one of the conclusions, that we should not go back to the Special Powers Act again, which was not tailored for pandemics, it was tailored for old-fashioned crises and so on. So there are many responses, and many of those are very political in nature. Over.
Very, very nuanced regulation, not a special powers. Actually, I saw Carlos Rezende gave a very good idea. And actually, you're absolutely right, Carlos. Let's go for one single option. Why not? Annalisa, if you haven't resolved, don't worry, because I like even more. Because policymakers like Lisa Maria here do not get many opportunities. Sometimes they have to choose one thing. So even better, let's put that and choose one thing. Let's put the voting now. And Natasha, I'll ask you to talk about the burnout issues as in your final concluding comments. I'll ask you to focus on that, as I'll ask you all concluding comments at the very end. So you, if you don't mind, Natasha, we'll go into the human resources, an area that you care an enormous amount. So let's go to the voting, please. So you remember by now still the questions? Okay. So I don't know whether you can vote one or more. Just try it. If you can vote one, you vote one. If you can vote more, you vote only three. The last, the eighth one that I was telling you was saying the opposite is true. In fact, more than efficiencies and quality, this focus of COVID-19 on hospitals undermines primary care, and this dominance of communicable diseases may undermine non-communicable diseases. That may be facetious, up to you to decide. Please go and vote and see what are the results today. Panelists, please do vote, and then I'll come to you. Maybe I'll start as to Isabel on reacting on the votes and on her own opinion on that.
Please vote 3 options. It works now.
It works now. Oh, perfect. Thank you. Okay, so can we start getting, I submitted mine already. So let's see what people vote. Annalisa is watching whether anyone is doing any cheating and voting all of them. So be careful. You'll receive an email tonight of those who are bypassing the system and trying to influence the real democracy. Okay, can we start seeing results? Meanwhile, Susie has some good points to hear. Susie?
No, just to say, since there's a small pause while we get the results, the questions that are left open are really the things to come towards the conclusions, in the sense of what are the benefits, which will be long term, which tries a lot with this one, how we get more agile policy. I guess that the points that have somehow slightly been left out are how would we manage to build confidence of users in the future hospital post this. And we're going to manage these two. Oh, good, we have the results. I stopped.
Excellent. Please, panelists, please do listen to that one, how to build confidence on our users again on these hospitals and on the managing of the crisis. Okay, let's see the results. So we all believe that there is indeed going to be an increase in IT, that would clinical networks as well, teamwork, excellent, good news. You all had to choose some, and these are clearly the improved care and patient pathways, the fourth in our ranking today. Interesting, efficient clinical research. So there's quite a lot of consensus there, but it's interesting that 13 and 14%, almost the same ones, probably that voted to 7 and 8. I would be very curious to know whether those who voted for 7 voted out of 8 as well, are worried about there'll not be sustainability, and perhaps these efficiencies are not as clear as we think. But most of our group here today seems to be optimistic and see the silver lining. Isabel, would you like to comment on those? What is your opinion? What did you vote for, Isabel? Tell us. Not as European Commission, but as Isabel de la Mata.
3-1. Yeah, I mean that in my view was easy, but at the same time I don't disagree with the 8. I mean, one of the problems that we have seen in this crisis is that primary healthcare has been forgotten, and even not only forgotten but even closed. With the excuse in brackets that people could be infected if going to the primary healthcare centers. I mean, we will see in the next month what will happen with all the chronic patients that haven't received attention during this month, with the ones that have escaped the screening measures for whatever. I mean, breast cancer, whatever cancer, what has happened with the diabetic patients. I mean, as everybody over 50, I am a chronic patient. All my consultations were cancer. I mean, in my case, was not a lot of impact. Didn't have a lot of impact, but for other people like our parents, yes. So this is a worry. But I think that it's sure that we are going to use more and more the IT system. All of us, we are teleworking. At the beginning, nothing was working. In March, that was a chaos, and now it's going well. So it's really not a problem. And the same for the health system. The problem that we have still now is the interoperability of all the different apps and telemedicine systems. Maybe not internally, but yes, across the border. And we have seen that things are happening across the border. And even if the mobility has stopped a lot with this pandemic, it still exists. So people don't are born and live and die in the same town, but they are moving. So we need to do more and more. Data sharing, that has been the basic of everything for the clinician to be able to respond to the crisis. At the same time, the teamwork, the change on this silos that we have, the intensivists, internal medicine, gynecologists, etc. This has been changed, and everybody is doing what they can, and everybody is learning from the others, and this is what we are also trying to do. That with this project that I mentioned before, that people that are not specialists in one area, they could support the real specialists, because at the end, all of them are health professionals and they have basic skills. And the networks of clinicians is what we had yesterday in this summer school, that they are really helpful using the European Reference Network as a platform, but the helping is changing. As Lisa Maria said at the beginning, we're just changing by the phone, but this is a more organized way of being able also to exchange the clinical records in a protected way and to learn from each other. So, and this has been working not only in the same hospital with people talking to each other, but among hospitals in the same country and among countries. And this has been a very good option and very good idea with very good results. So I think that those, for me, have been the case. Okay.
Thank you very much. Can I have other views on that, on these results of this voting from any of you? Reinhard, maybe in a minute I'll ask you for the conclusions of the summer school, but if you want to make any comments on this voting, any of you, you've been surprised about those results? What were your votes, Natasha, for instance, Lisa Maria, Martin?
So I was relieved to say that Isabel was also intrigued by point 8, because I mean, for me, 1 and 2, the clinical networks, the IT, those are clear, but I also see number 8, and this worries me very much. That I think one of the things that we are really grappling with is, on the one hand, we want to protect hospitals, and therefore we want that patients with symptoms in autumn and the fall, be it ILI, influenza or COVID, will be able to be cared for by primary care. At the same time, one could almost argue that you turn it all on its head, and you say that primary care should really be the place where people who don't have symptoms are going to continue their chronic disease management, their follow-up, and that we create a separate and dedicated patient pathway also in the community, but clearly as something special to deal with this exceptional situation, in order not to dissuade and discourage people, like my mother, who called me to say she's cancelled all her appointments again because over the weekend we have had a resurgence of cases of COVID in Malta. And this is just, I think, really some of the fear that is taking place also in the elderly people who have to balance then. What is the most risky? Is it going for the appointment? Is it my chronic disease management? And I think that we're really struggling to find the fine balance over there. Just if you would allow me, Joseph, to return to the point on the health workforce.
Let me ask you, Natasha, to bring that issue at the very end on your conclusions. What I'd like to do now, colleagues, is ask Reinhard to give the conclusions of his own reflections of the summer school today. Then, until today, I meant. Then each one of you, very brief comments, and then Natasha, if you could conclude with the workforce. Also, I like participants, please, to add in your chat box now. So Susie will be your representative on what were your lessons, please, those participating. And I'll ask as well Antonio Maritati, our host these days, virtually, because unfortunately we're not in Veneto, although we had an excellent session about the successes of the region, to join us, Antonio, as well, to give your own conclusions to what you learn in the summer school. So first, Reinhard, to give us the conclusions. Then I'll ask each one of you a couple of minutes maximum, please, to give your own conclusions. And then Susie will finish with the conclusions of the participants. To recall that we were meant to do 2-hour session today. We put 2 hours, but I think we're all tired, almost the end of the week. So we'll try to finish well before the 2 hours. So if you give me another 15 minutes, we will wrap up this last wonderful, I think, great session. I don't want to sound like President Trump, great session of the summer school. So Reinhard, you've been uncharacteristically silent today. I've never seen you so silent, but now I expect your conclusions.
Yes.
And thank you for the leadership and the preparation of this summer school.
And
Reinhard.
I start with Antonio's nice background. I mean, usually we are having the summer school in Venice, and clearly the whole environment is lacking here when we only see each other via Zoom, and the social networking, which is part of a summer school. I mean, this could also be in winter here. And originally, as you all remember, we were having it on the future role of the hospital, and then the COVID sneaked in, which not only meant that we had to do it online, but which also dominated much of the discussion. And I think today is particularly driven by this, and also the questions. We see that people always, and clearly it is a sign that the role of hospitals is not independent from the rest of the health system. And if we talk about COVID, we have to see the whole picture. And somehow the COVID crisis is like a magnifying, a burning glass of the situation. And many of these issues, which we would have discussed anyway, came to the forefront, like the role of professionals. I mean, we in this time, suddenly, even for normal people, policymakers, they realized how important health professionals are. We have heard the question now, jumping a bit on the burnout. I mean, we all think they have burnout. We also know, at least in Germany, that the employers, the hospitals, the ambulatory care networks sent more than 400,000 health professionals in short-term work because there were so few patients. They sent their staff home. So we have all these different realities. We have clearly the importance of technology. I think most policymakers were never aware what kind of technology is actually existing in intensive care units, that you need ventilators and dialysis equipment and all this. So we all did a leap jump in learning there. And the necessity to evidence. I mean, when have we ever experienced that normal people say, you know, I need more evidence, or this evidence is not good enough? I mean, we are always saying, as a European Observatory, we want evidence-informed health policy. Usually, we had to explain what we mean by evidence, and now everybody is asking for it. And probably the fourth one of these things, which I want to emphasize, is the role of hospitals itself. So are hospitals independent institutions? And many countries have made their hospitals more independent, whether you call it trust or foundation trust or public enterprise or whatever, that we have given them autonomy, thinking that they themselves can make better decisions. Now we realize suddenly some of them didn't buy protection material. And then the same hospitals which were always asking for autonomy, and then we say, wait a minute, why didn't you think of a crisis and didn't have any protective material? And so we are now, I think, reconsidering, are hospitals really independent entities, or are they part of a closely managed network, or should they be part of a closely managed network?
Okay.
And I think everybody agrees that the current crisis will have consequences. But I'm not sure whether, I mean, but people who agree that it should have consequences are often thinking of totally different consequences. I mean, once, and we have heard good examples here from the Veneto region, for example, how they have kept patients out of hospitals during the COVID situation, something similar which we saw in other countries. And these countries, I think, rightly say, I mean, you know, we safeguarded not only our hospitals by keeping patients out, but also the patients themselves, that they didn't get infected while they were in hospitals, while other regions, often hospital staff itself, I mean, we have seen in France, for example, I mean, 70% of all SARS-CoV-2 positive patients were hospitalized, 70%, while in other countries it's like 15%. And so when you talk to people in these countries, they will say we need more hospitals. And so yes, everybody said we need to reevaluate the role of the hospital. But how should that look like? And suddenly, and also people were saying we need beds. Then we say, wait a minute, beds weren't this thing which we thought in the Middle Ages. I mean, when we did not have technology, hospitals were made out of beds. But suddenly there are people back who think that beds can make the difference. And I think we have heard questions here also from participants whether you need isolation hospitals. And you say, why should you isolate people in hospitals? Why don't you isolate them at home? If they are not ill, they don't have to be in a hospital. So I think some really basic questions come up. And yes, innovations. Yes, we need innovations, and probably we need to configure that. We see that we need innovation within hospitals, across specialties, but we also see fights. In Germany, we recently had a fight that the pneumologist said the COVID patients are treated in the wrong departments. The intensive care people don't really know enough about the lungs. So the COVID patients should actually be treated by us. And so, while we see positive examples of people who say we should collaborate within hospitals across specialties, across professions, doctors and nurses, they are also opposite views. Across hospitals, yes, across hospitals within countries, we need to coordinate who treats COVID patients, who doesn't, up to, to the idea which we also discussed during the summer school of the European reference networks. So how much to really countries, and because now we have the debate, we all remember that we say we cannot buy protective material in China. We need to bring back the production home. And I'm sure we will have soon the same debate on hospital treatments, that we don't want to rely on other countries. Maybe the border is closed. So what then is the nice European network good for if we cannot go there? Okay, maybe the digital way will still be there, but so I think we are challenging all this, and last but not least, it is still due, even though I think we have all widened our horizon, that some of us need to even do more of this horizon widening. Hospital doctors need to come out and see, yes, there's an ambulatory care sector, and they can also help. There are public health offices which can do the testing. It's not only the hospitals, but vice versa. Policy makers, ambulatory care physicians should. Maybe they haven't seen a hospital at all, or they have seen the hospital the last time for 20 years ago. They need to realize that hospitals have changed. And I think that's why I, by the way, put the last question. I put the last answer. I'm not sure that we are really on the right track. We all agree something needs to happen, but whether this will really lead to improvements is up to people like us to ensure this. So things like the European Observatory on Health Systems, summer schools like this are even more important. Thank you.
A sweet, sour message at the very end, but beautiful, beautiful, beautiful. Thank you very much. You managed to condense lots of key messages. I would love to comment if we had time. And I see the participants bringing lots of stuff. Susie, you must be very busy now because lots of good stuff. Can I ask the panelists, please, 1 minute each approximately? Maybe I move to the second director of summer school, Martin McKee, to see what would be your reflections, your closing reflections, then followed by Lisa Maria.
Yeah, sure. Well, no, I echo what Reinhard has just said. Obviously, as the summer school would be in Italy, it's probably appropriate to quote Giuseppe Tomasi de Lampedusa, who said that everything must change for everything to stay the same. And that too often, well, I thought I'd introduce an Italian element at this point, albeit the other end of Italy. So, yeah, I think one of the things that comes out of this is that it is absolutely crucial that we encourage a dialogue between clinicians, policymakers, politicians, and others, because often we just have two groups shouting at each other or ignoring each other. And, you cannot develop a policy in hospitals if you don't know what goes on in hospitals. And I think it would be instructive for, we have really struggled. And this is, again, given my criticisms of the UK, it's one thing that does work relatively well. We do have national clinical directors who engage with ministers. We do have leads in cardiology and care of older people and frailty and things like that. We need to get that dialogue going from both directions. Policymakers need to go into hospitals, walk around them, spend a night in them, and so on, to really see what's going on. And at the same time, clinicians need to, recognize that they have to talk to policymakers. And if we can get that to happen, and, God knows I've tried over 30 years, it's very difficult. But, I'll keep trying for a few years more and then give up.
You know what would be the solution, Martin? To have Lisa Maria or Lisa Maria's CMOs, Director Generals, who actually have been in hospitals, have been and are clinicians. I think that would be the ideal. Lisa Maria, I'm sorry to be nice, but you deserve that I'm nice, because the work you did over your career and these days is amazing. Up to you, Lisa Maria. Back to you now.
Thank you, Joseph. First of all, on behalf of all the partners of the observatory, I would like to thank Reinhard, Martin, you, Joseph, Annalisa, and Susie for organizing all this. I think that as the observatory, we can learn from this exercise also. We will definitely go back to the summer school as it was, but perhaps we could add an element of the webinars on top of that for the public good and for wider audiences. For conclusions, I would love to address many things, but I limit myself to just one. We still don't know how this epidemic and pandemic will end. There are too many open questions. But at the same time, our health systems have been in the limelight. I very much like what Reinhard said about the health system being back to the center of policy making. And since under this tremendous pressure, we did many things differently compared with our usual normal practices. Could we learn from that? Could we actually consider not going back, doing things the way that we did them before the epidemic and pandemic? Could we actually change our thinking and our practices? I'm just taking telemedicine and IT as an example. Even the university hospitals realize that they can rely more on running their clinics with video chats with patients who knew them well and they knew the patients. You need not go to the hospital as an outpatient, which is the Finnish way of treating many chronic conditions in hospitals. That patients come there to polyclinics on a regular basis. You can use video meetings, video chats for much of that. So this kind of lessons, could we learn them and could we make our practices? And thank you so much for organizing and inviting me also to the final panel. Over.
Thank you very much, Lisa Maria. Isabel, a lot of the innovations we've been talking about, clinical networks, hospital networks, the use and standardization of technology and data goes through the Commission and goes to the Commission. I mean, the role of the Commission can be very, very valuable in supporting that. What will be your conclusions today?
Well, thank you very much for organizing this summer school. I'll join the previous speaker in saying that I hope that next year we will be in live, seeing each other in direct in Venice. I hope that, because this has been ongoing for many years and is very useful. And it's not the same to be able to discuss over a coffee in the coffee breaks or in the lunch and etc. that being here in the Zoom. That is interesting and is able to tackle more people, but really it's not the same. It's not exactly the same. So and the Commission will do the best. It's best to support the member state in these challenges in hospital, but not only in hospital. One of the main lessons is that we need to reinforce the health system as a whole, and that we seem over the years to have forgotten about what before was a mantra, that was Alma Ata and the primary healthcare. And we have been trying to recuperate in the last year with a new name that is all the integrated healthcare. Basically is the same, but taking into account that everything has to be a continuous single health systems, and that the healthcare system has not been isolated of the reality. So if the population is using more and more apps and more technology, the health system has to use more and more apps and more technology, because it's part of the overall society. But taking into account that we need to ensure that this does not increase the vulnerabilities and the inequalities in the access to healthcare for the, especially for the elderly population that are not so comfortable with these new technologies, and the population that have less access to the technologies. But I think that we have learned a lot from this crisis. And all the different elements of the health system, from the primary health care to the hospital, have learned a lot of this crisis, and we continue to improve and to work together. And this is also another important issue that we have learned, that the teamwork is really important, and is the thing that is going to save us, to work in collaboration. Thank you.
Thank you very much. And talking about collaboration, Natasha, thank you very much as well for the double job in a co-organizer of the summer school and leading us so well as well. Natasha, some final comments, please.
Thank you very much, Giuseppe and colleagues. Of course, there's absolutely so much that I would like to say. I think Reinhard and Martin's comments themselves have unleashed enough material for us to go on for hours. But let me just limit myself to say that I hope that when we meet in a year from now, we will be able to say that some of the good and innovative practices that we have seen introduced have been retained and have started the road to achieve that long-lasting and sustainable health system transformation using technology and using integration, which we really need in order to meet the legitimate expectation of our citizens and patients, but also in order to safeguard our health workforce. Our health workforce is a very, very scarce resource. And our health workforce, yes, of course, is burnt out, has had to deal with a lot. Some of them, for example, have had to deal with some very difficult moral dilemmas, both in terms of patient care, particularly at the start of the epidemic, when there may not have been enough resources, when not enough was known. Also dilemmas between the needs of their families, their children, the needs of their profession. And it's not just the long hours that cause the burnout, but it's all this complexity. But how can we show real respect for our health workforce by investing in the technology that they need to complement, to relieve, to address their focus and their energy, where it can make a difference on where to work, where they like working, where they feel safe to work. The long-term care workforce, what is long-term care? Long-term care is caregiving. It depends on the workforce. Some of these people have really been left behind, and there's a huge revolution that needs to take place just in long-term care alone. Of course, we need to look forward. As WHO, we have a big initiative being planned about looking forward, about really reminding us all that health systems, work, and finance, at the end of the day, are all means to an end, which is what we strive to achieve, which is a better quality of life for European citizens and people. And just to say to Martin that you might be giving up the baton in a few years' time. I doubt you will. But I feel that our mission in public health is precisely to keep walking that bridge, with the famous Westminster Bridge, which you have in London, from the hospital on one side and Westminster on the other, and really bringing the politicians and the clinicians closer together. That's our role. And as long as I have the energy, I will continue to follow that path. And thank you very much for the work that all of you have done on the COVID monitor and in the past months. It's been really appreciated by all the member states.
That we do together, Natasha, with you and the European Commission. Antonio, thank you very much for joining us in these concluding comments. Thank you very much for hosting us in Veneto. As I said, not only because it's such a beautiful place, but because you're such an innovative region with lots of dynamism, as we heard a few days ago in your presentation. Any concluding remarks from your perspective today, Antonio? And then I will move to Susie and the summary of what our participants are saying. Antonio.
Sì, grazie Joseph.
Thank you very much, Joseph. Thank you all
for intervening. I'd like to make 3 brief comments to conclude the very important speeches that we heard today and in the previous sessions. Well, first of all, I'd like to congratulate the observatory. Right from the start, you were determined to convene the summer school, notwithstanding the very difficult predicament we are in. This is the first thing I want to say right from the start, and for which we are grateful. Notwithstanding the period of crisis and of pandemic, the summer school had to be convened. We are here on the web. It's a modern way of meeting. But the most important thing is that the summer school has happened also this year. You were supposed to speak about the hospital of the future, and we have decided to speak about the hospital at the time of COVID. In Italy, in Europe, in all the other continents, we had to face this very difficult situation without a guiding handbook. The situation was unique and unprecedented. Thanks to the lectures of these 2 weeks, hopefully, we all have more information available and we are more prepared. We are ready to face a second wave of the disease, if any, and we are also ready to face new innovative strategies and to implement them. So what is good is that participants could gather more information in order to make the decisions they will have to make in the coming months. And that is my second comment. My third and concluding comment, because I don't want to take away much of your time, is a wish. I hope you could come next year. I hope we could meet next year in person here in Venice. The physical distancing, the fact that we have to stay away at least 3 feet from other persons, that should not become social distancing, because being together and with other people and to collaborate is one of the key values which make the summer school so special. These are my concluding remarks. Thank you very much for organizing the summer school. Thank you for your availability and your professionalism. Thank you very much, Joseph. Thank you all. Thank you, Antonio, for your comments. I hope that we all have contributed to add some lines to the COVID handbook.
And to say, of course, that next year for all of you will have, clearly, Lisa Maria, you were saying that we'll have the double version. Those who be in Veneto have the opportunity, not only coffee, but perhaps some Prosecco and good debates, but also webinars so everyone can participate openly from now onwards. But now, most importantly, Susie, thank you for working so hard there. What are colleagues saying? And you may want to add your own contributions as well, but thank you today for being the spokesperson and the advocate of the participants.
Can I say that thank you very much, Giuseppe. I have to add very little because there is an extraordinary degree of consensus, both around what people are saying on the chat and in the questions, but also the feeling that the people who've summed up have done an amazing job, and that Reinhard and Martin's presentations, Natasha's, Isabel's, Lisa Maria's, have really pulled out some of these amazing themes. I think the first thing is to say that a lot of people have mentioned last week, which was less COVID focused and still clearly very useful, a lot of a sense of appreciation. And then perhaps 2 kind of groups of messages that we've all learned a lot about. The need for flexibility, the capacity of individuals to be flexible, that sense of new ways, the need to think and link things differently. So what I think Reinhard called horizon widening, with kind of people pulling out as examples the fact that the ICU in Finland has got such an incredible ability to integrate and communicate. And again, with the example of in Veneto of the nursing homes and the links between the system, and again, all the discussion. So lots of stuff around the need for that and what people have learned about that. And then I would think as the kind of concluding group is lots about the need for transparency, for sharing, from learning from each other, from being open, from acknowledging mistakes. And I think, you know, that sense that the summer school has been an opportunity to do exactly that, to learn from each other, from each other's successes and failures, I think is really sums up what people are feeling in the chat. And that, I think, is really the key thing. That's
Thank you.
And
can I ask Annalisa and Simone and colleagues to come on the screen as well, because we haven't seen them. And I really want to thank Annalisa, first of all, because she organized, she led, she contributed, she supported. She's been really, really nice, steering us, pushing us, making sure we're prepared. And you managed to run so smoothly, so beautifully. And please, Simone, come up as well for the enormous support you've given us when we are in the island and when we're here. So thank you very much indeed to both of you for this enormous support and leadership, to participants, and to remind you watch this space, because next year you'll all be able either to come to the island. Remember that our prices are very, very low, just you pay for your trip and for your hotel. Sorry, I'm not embarrassing you, Susie, I hope. And if you cannot afford that and come to the island with us, you'll be able to join us webinar and have this debate. Thank you very much for sticking with us all these days, following the lessons, the lectures, participating, and these beautiful comments. They warm us up a lot, and particularly Annalisa and Simone and the two directors of the summer school that worked so hard on that one. Thank you very much indeed. Have a beautiful summer, and I'll see you soon, very soon. Bye-bye.